to talk about chapter 16, which is schizophrenia and schizoaffective disorder. The majority of our time, majority of my videos, everything is going to be related to more schizophrenia, not schizoaffective. I'll give you the difference between the two, but schizophrenia is much more of a common diagnosis. It's easier to diagnose than schizoaffective. See if I can get this guy to go full screen for me. Look at that. We're 2 for 2 this week. Let's go. All right. So let's talk about some preconceived notions about schizophrenia. What do you guys already know, or what do you perceive to be true about schizophrenia?
They are unpredictable.
Okay. Unpredictable. That's a good way to put it, for sure. What else?
False sense of reality.
False sense of reality. Cool. Definitely. What else? Faith. What comes to mind with schizophrenia?
Voices in your head.
Voices in your head. Interesting. Okay. Maggie. Not in touch with reality. Very good. All different ways to kind of put these weird delusional thoughts. There's some other aspects that are a little bit more, I guess the right word would be maybe aggressive symptoms of schizophrenia. Maybe you have heard of, maybe you haven't heard of, that make it the reason why it is very stigmatized. Okay. All right. So some conditions of schizophrenia. At least 2 of these symptoms have to be present for at least 1 month. Okay. So you have the delusions, like a non-bizarre delusion or a bizarre delusion, meaning something, it might not be a very weird delusion, it's just not true. Okay, delusions are not true beliefs. Schizophrenia is very, very complex. Every person varies very different. Like one person's hallucinations and delusions are going to be totally different than another person's. They're going to present differently. Schizophrenia is hard to diagnose. Schizoaffective is even harder. Another one is hallucinations. So the seeing, feeling, that all involves your senses. I'm going to dive into that a lot here in just a few minutes. Disorganized speech, disorganized or catatonic behavior, just random behavior. Negative symptoms, which I'm going to talk about what negative and positive symptoms are, because that's going to be extremely important for your exams, okay? In addition to all of those symptoms, they have to have they can have all these symptoms, but if they do not have a marked decline in their function, okay, then it is not diagnosed. They have to have a marked decline in their function. So delusions themselves are distorted thoughts or false beliefs, okay? Hallucinations are distortions in perception. They're both related. Normally it's one and the other. They kind of coincide, but they are different. Hallucinations involves like your senses and feelings. It could be the sense of feeling like spiders are crawling all over your body all the time, or seeing spiders crawling all over your body, or, seeing a pink elephant in the back of the room holding a knife. I mean, it can be totally off the wall, completely random, no rhyme or reason to what a hallucination or delusion can be. Okay? It has to be persistent for at least 6 months, okay? These hallucinations and delusions. And these symptoms will be very downplayed or less severe in these residual periods between these flare-ups. This is the way that I hope it. Flare-ups is not the correct word, but I think it makes you understand a little better. Is, they'll go periods of time and not have these really bad hallucinations, but all of a sudden, it'll get back up. During those weird off times or normal times, they are probably going to have more odd beliefs. They're going to have more of the delusion behavior rather than the hallucinational behavior. Make sense? All right, so the idea of positive and negative symptoms. Just because something is called positive does not mean good in this sense, okay? Positive symptoms mean they have gained something. Again, doesn't mean it's a good thing. This is the hallucinations, the delusions, disorganized thinking, disorganized behavior. These are positive. They gained this type of symptom, okay? Negative means they have lost something. This is where they may have a flat affect or no emotions on their face. Social withdrawal. These type of symptoms actually have a greater impact on functioning as far as we're concerned as occupation goes.
The negative one?
The negative ones have a greater impact on functioning than positive ones. This is where their personalities is literally being stripped away from them during these times and flare-ups. Okay? Does that make sense? So everyone understands what a positive and a negative symptom is. Positive does not mean a good symptom. It just means that they have gained some type of a behavior or symptom. Negative means that their personality has been stripped. They have a flat affect, stuff like that. Cool? All right.
You can have both of those symptoms at the same.
Yep.
You want to get any coffee?
Yes.
Okay. Go ahead.
Cool.
Well, I guess. I mean, she never logged on, but then I realized that she meant 10:45 her time, not our time.
Oh, crap.
The doors closed, so I'll work it through. Oh,
So
no.
that's 2 or 3 hours from now.
In 2 hours.
That's very true.
Yeah. I was like, she don't want me in. I was like, she meant her time.
While she's getting some coffee, I'll give you a little catch up with us because I've only gone through a couple slides, okay? So schizophrenia, we talked about the description of it, okay? They have some of the criteria here, delusions, non-bizarre delusions. So it might just be a false belief. It's not really a weird belief. It's just, not true. Then bizarre is something off the wall kind of belief, okay? They can have all of these symptoms that are listed on that slide, but if they don't have a marked decline in function, they're just not going to work, things like that, then they don't gain the diagnosis. They have to have marked decline in function. And if they have these, they do. It's normally not. Delusions are wrong beliefs or thoughts. Hallucinations are distortions in perception. So this is all of their senses. They may see something that's not there. They're going to hear things that is really not being said. They're going to feel things on their skin that aren't there. Those kind of things. That's a hallucination. Cool. The only other thing, and you can go through it, this is being recorded too, so it'll be up on eLearn. There's a couple of things I mentioned, but the other big concept is the idea of positive and negative symptoms. Positive symptoms are hallucinations, delusions, stuff like that. Positive in this does not mean good. It just means they gained a symptom, okay? So it's like a positive gain, not a good gain, okay? Negative means that they have like the flat affect. They don't have emotion on their face. They lost a piece of their personality. That's a negative symptom, okay? And that's pretty much caught up now. Cool. Coffee break over. Good timing. All right, so some subtypes. There were subtypes that were listed in the DSM-4, but those have been removed. Those are not there now. There are symptom clusters, but they're not subtypes of schizophrenia. You have psychotic, disorganized, negative, and affective domains. If you guys have your book, go to page 227 for me. Sorry. For those of you that are not slackers, please bring your open your book to page 227. This is so important for your exam to know this table. You're going to want to know it like the back of your hand, okay? It's table 16.1 on page 227. The psychotic symptoms, this is the hallucinations and delusions, okay? I think we've covered pretty much what those are. Then you have negative symptoms. Some that are going to be on your exam I haven't mentioned yet are in this table. You have, I always mess this up. Alogia, something like that. Anyway, speech is characterized by limited spontaneity, reduced amount, or impoverished content. It's just kind of all over the place. Okay, the flat affect, that's the reduced intensity of emotional expression, not showing any emotion on the face or gestures or anything like that. Avolition, this is difficulty initiating and carrying out goal-directed behavior. Anhedonia, this is the inability to experience pleasure, even when it's something that they typically enjoy. And then attentional impairment, this is just difficulty concentrating. Okay, you're going to want to know all of those. Got me? All right, some disorganized symptoms. This is the disorganized speech, disorganized or bizarre behavior, or an inappropriate affect. They may be giggling during a funeral, stuff like that. It's an inappropriate affect. It does not match the situation that they're in. And then the affective symptoms is manic, that's the elevated mood, or depressive. We kind of had a whole chapter on that, so I think we got that right. Cool. Any questions on those? You know, they're not subtypes, they're symptom clusters. Okay? Cool. Review that table and review it 4 more times. Cool? By the way, you guys are going to be competing in our next exam review. We're going to do it another Kahoot, and you're going to be competing against Beckley. And this is for huge bragging rights. So I just...
And bonus points?
And bonus points. I will give out bonus points to the highest. I don't think so. I'll probably do 5, 3, and 1. It's going to be individual. You guys against them. May the best man win. Or woman win. Sorry. May the best person win.
Yeah, can't.
That's harder to do, but fine. Maybe. I'll talk to Professor Masilli. We just wanted, because apparently they have this rivalry with you guys that I was like, we haven't even done anything with them yet, but they have like this thing that they want to prove that they're better than you guys. I said, well, they're not.
Oh.
And no, swear. I really am.
So they talk about us a lot?
Apparently so.
They're obsessed with us.
Yeah. Yeah, I have found out that they have this unsung, rivalry. I was like, why? Well, like last year they had a huge one, but we did Cahoots a lot together and stuff like that. Not this time. I was like, all right, well, we'll just take them down and be done with it. Move on about our lives. So you guys get to meet him next week, though, so you can talk smash like Beckley who and stuff like that. That's what they always said to Beckley last year, like Beckley who. All right, so schizoaffective disorder. Sorry. This is a combination of psychotic and mood symptoms, okay? So this is the affective disorganized symptoms as long attached with the psychotic symptoms, okay? So that's why I bring up the symptom clusters, because schizoaffective disorder is characterized by the psychotic and the mood symptoms, okay? That the criteria must be met for schizophrenia first and for a depressive or manic mood disorder. These are together, boom, it creates one disorder, okay? Got me?
So they have to be schizophrenic first.
They have to meet the criteria for schizophrenia and a depressive or manic mood disorder as well.
Okay.
Yep, you have to have both. Cool. All right. That's really the big distinguishing factor. However, they can't diagnose schizoaffective disorder on the first episode of psychotic symptoms. This has to be something a little bit more prolonged. This has to be multiple times. Cool. All right. So let's talk about some causes here. As far as genetic factors go, twin, family, and adoption studies say that there is a genetic link to it. There is no biomarker or anything in somebody's DNA that says you are going to get schizophrenia. There's nothing for that. And then it's different for each individual. Just because, a mother has schizophrenia doesn't mean the child's going to have it. There may be a biolink, but there's not really a lot of studies out there saying that there is. Okay. As far as prenatal stuff, maybe oxygen deprivation during birth, birthing complications may make someone at high risk to develop schizophrenia. Structural and neuroanatomical differences, there's not a big one. There's not a different brain makeup. There's different brain activity, but there's not like on some of them where we said the prefrontal lobe is smaller, the amygdala is, large, anything. There's not that. This is differences in brain activity. Okay. One of the biggest theories is associated with dopamine, and it's also old. Anybody remember what dopamine is? It's our happy chemical. Yeah. There's an increase in dopamine when they're going through these episodes or flare-ups, as I told you to think about it. And it is less dopamine when they're not having an episode. So that's why it's one of the oldest theories that's out there. They still don't really know why dopamine plays such a large role, but they know that there's a link there that kind of shows dopamine is a factor. Another one we've not really talked a lot about, maybe the last chapter about stressors, maybe a little bit, but stress vulnerability. Write this theory down. It's called the diathesis stress theory, DIATHESIS, stress theory. This states that exposure to stress is necessary for individuals that are biologically predisposed to schizophrenia to express the condition. So this theory says that if the person does not experience stress, the symptoms do not come out. That's what this theory is saying. It's saying that stress is necessary for these behaviors, these hallucinations, for these delusions to be present. It's not necessarily saying stress has caused them to develop it. It is just saying that's the trigger, more or less, for the symptoms to become present. And then last is the specific environmental factors. Social disconnection is one factor if they don't have a lot of social interactions, not a lot of friend groups. Actually, marijuana use at an early age and very heavy use can exacerbate symptoms or make them worse. Very small group. I don't even really like mentioning it because when you look at the study that says it was a very, very small subgroup of people that developed, schizophrenia later in life. It wasn't, and it's a study, so it can change. But anyhow, that was one small environmental factor. The biggest one is social groups, lack of social interactions and friend groups. Okay, we good? All right, prevalence and course. It's actually really low. It's not a lot of people have schizophrenia. It's not something that's super common. I think that's why it's got such a stigma around it, because when people find out someone does have schizophrenia, they're like, oh wow, they're weird, and it doesn't have to be that way. Typically diagnosed in someone's early 20s. However, it can be diagnosed a little bit later, but it's not normally diagnosed after the age of 40. So early 20s to about 40 is really your range to be diagnosed. Late onset is more common in women than it is for men. You have what's called the prodromal period. This is the time between when they first got symptoms and when they met diagnosis criteria. So when they started having symptoms and when they finally got the diagnosis. Okay? Early intervention is receiving a lot of increased attention, like all other mental health disorders, that if we intervene earlier, the outcomes are normally better. One of the most effective treatments and stuff is cognitive behavioral therapy, that CBT that we've talked about for a lot of these, right? While they're in this prodromal period where they're still having symptoms, but they haven't gained the diagnosis, they might have a better outcome if they're going through things like CBT. Okay? All right, some gender differences. It's slightly higher, actually, among males than it is for females when we talk about schizophrenia. Women tend to experience more depression. That's how schizophrenia will manifest. And then they'll develop the condition at a later age in life, again before the 40, but maybe not in the early 20s. Men experience poor outcomes, more cognitive impairment, and are more likely to manifest in substance abuse. Okay? I mean, without giving any names or anything like that, has anyone had a personal experience with somebody with schizophrenia?
I work
Ever?
with people.
You work?
Client work.
Yeah. Yeah. I've worked with someone too that had schizophrenia, and I knew it, but he never acted different until he had a flare up. And I was with him one day at work when he did have a flare up, and I found him like panicked in the walk-in cooler, like in a corner, just terrified. I was like, what the heck's wrong? And come find out he was having a flare up, and he had to go to a mental hospital and everything to get it to calm down. It was a big ordeal. That's my only personal. I have worked with patients before, but they weren't actively flaring up. So, anyone else had any interaction with someone with schizophrenia before? No. That's what I'm saying. It's not. I would talk about, has anyone experienced or seen someone with anxiety before? Much more common. This one's kind of rare, unless you've worked in a field with people working with disabilities or mental health disorders. You normally don't. I have had patients that have had it. Sometimes they have odd. They normally always have an odd or a weird belief. They're very big into conspiracy theories. They will believe just about any kind of conspiracy theory. But overall, I've not worked with a whole bunch. As far as culture goes, we need to mention that with schizophrenia, because certain aspects and certain behaviors of schizophrenia are acceptable and normal in different cultures, different religions. So you need to be aware of that. Sometimes people are overdiagnosed because of just completely misunderstanding their culture. Like in a lot of cultures and religions, it's common to hear the voice of God and things like that. That would be seen to a lot of cultures and religions. That's a normal aspect of it. But to a psychologist who doesn't understand the cultures, like, oh, they have schizophrenia. That's not necessarily true, right? So it needs to be understood better that culture it plays a huge role into our behavior and how someone can get diagnosed. Okay. As far as the impact on occupational performance, of course, you have the cognitive impairments. This is difficulty with attention, memory, executive functioning, and information processing. Difficulty with their working memory. This leads to stuff all over the place, right? This is going to interfere with school, work, play, social interactions, all that stuff. Health and wellness, you're going to have a higher rate of mortality among these people. They have a much lower life expectancy. Suicide is a huge risk of people that suffer from schizophrenia. They often have poor lifestyle behaviors, common to have comorbid with obesity and diabetes, higher rates of smoking. Some things you got to look out for with, and I'm going to mention this a couple times, but often you'll see people with schizophrenia have bad teeth. And it's because a lot of the medications that they use to treat schizophrenia results in dry mouth and stuff like that, can lead to teeth rot. So that's another common, comorbid thing. But the medicines have those kind of effects. They can even cause tardive dyskinesia, a whole bunch of stuff. So we'll talk about those again in a second. And then stigma and poverty. Stigma is the most difficult barrier to get somebody to engage again in the community after they've been diagnosed with schizophrenia. Once they know, other people know about it, it really is hard to get that stigma taken away. They often have a much lower quality of life because of this. Going to have trouble keeping and maintaining successful employment. They're often going to live in poverty because of that. And then, all around just not going to have a good quality of life because of the stigma. That's the biggest thing that we're going to face when we're dealing with schizophrenia. As far as the interventions go, on page 233, there is a table 16.2. You'll notice that these are very common interventions for a lot of mental disorders. This is the CBT, the cognitive remediation, sensory rooms, all that stuff. Okay? Talk a little bit more about medications. Some different antipsychotic medications that are going to be used there's two different classes, and you're going to know both of these, okay? First generation antipsychotics and second generation antipsychotics. They both have a lot of side effects, including sedation. Sun sensitivity is a different one. Dry mouth, constipation, blurred vision, orthostatic hypertension. Do you guys know what that is? It's where your blood pressure either shoots up or hypotension will shoot down whenever they change positions, when they stand up. Do you guys ever, when you roll over in bed and sit up in the morning for the first time and you get kind of lightheaded for a second, have you ever experienced that? It's orthostatic hypertension. Blood pressure dropped. Some more serious side effects are movement disorders. It can even look like Parkinson's. disease.
So what are these drugs?
Trying to keep the hallucinations and delusions under control. More so hallucinations than the delusions. Delusions in and of themselves are not considered. A lot of people will have the delusional behavior. Remember, those are more common during the down periods of flare up. Those are considered to be more acceptable, I guess, because it is just a weird belief. It's not necessarily affecting their functioning as much.
So is this something that can be like manageable, like bipolar medication?
Yep. And I've got some really good videos showing you people that are adults that have overcome it. Actually, in the TED Talk, she's actively having a flare up and will tell you what she is seeing. Got some cool videos.
It's like that, A Beautiful Mind.
Yep.
I mean, you were a professor eventually, wasn't you?
Yep. Yep.
All I can think of is Fight Club.
Jennifer. All right, I got a good video here. I'm gonna make the screen a little bigger so you guys can see it. This is what I think this one even has. Are you kidding me?
Go to the actual YouTube. Maybe it's on there.
All right, I'm gonna go ahead and stop the recording part because that's it for the lecture.
Is that not schizophrenia and bipolar?
I don't think so.